Supporting primary care providers in colorectal cancer screening. ColonCheck was established in April 2007 to help detect colorectal cancer early and reduce the number of Manitobans who die from the disease. ColonCheck invites eligible individuals 50 to 74 years of age to screen for colon cancer using a guaiac fecal occult blood test, or Fobt, and to provide timely follow-up for those with abnormal test results. ColonCheck actively works to increase colon cancer screening rates by mailing screening invitations and test kits, sending reminder letters, working with primary care providers, and providing education about colon cancer. We also coordinate follow-up of ColonCheck screening tests, including sending test results, scheduling follow-up diagnostic testing, and providing pre-colonoscopy assessments. We collaborate with stakeholders to improve operations, increase awareness, and reduce mortality from colorectal cancer. We have a confidential registry that includes a regular population upload from Manitoba Health that includes demographic information on Manitobans 50 to 74 years of age and Fobt and colonoscopy billing information. This information allows us to identify individuals who are eligible for screening, provide screening histories to clinicians, reduce overscreening, target underscreened individuals, and evaluate the program. That being said, we also rely on the public to self-exclude if they have had a screening test recently, as our database may not be up to date. In Manitoba, there are approximately 900 people diagnosed with colon cancer each year. Colorectal cancer continues to be the second highest cause of cancer deaths in the province. In women, it is the third most common cancer diagnosed in Canada and is the second most common cancer diagnosed in men. Sadly, there are approximately 300 annual deaths from colorectal cancer. Colorectal cancer refers to cancers found in the colon or rectum. We say colon cancer when we talk with the public, but we are really referring to colon and rectal cancers. What we know about risk factors for the average person is that people over age 50 are at greater risk of being diagnosed. Over 94% of those diagnosed with colorectal cancer are over age 50. Individuals with a personal history of adenomatous polyps, ulcerative colitis, Crohn's disease, or colon cancer are at a greater risk of developing colorectal cancer. A genetic predisposition, which includes a strong family history and inherited conditions such as Lynch syndrome, is also a risk factor for colorectal cancer. As well, lifestyle choices such as smoking cigarettes, drinking alcohol, and eating red meat and processed meats, and carrying excess body weight, particularly in the belly area with belly fat. There are normally no early symptoms of colorectal cancer, and this is why ColonCheck recommends that eligible men and women aged 50 to 74 do a home screening test every 2 years. If someone is symptomatic, they may experience visible blood in their stool, persistent abdominal pain, change in bowel habits that last more than a few weeks, or unexplained weight loss. It's very difficult to clearly quantify familial risk. However, research has indicated that familial risk can be classified into 3 categories: average risk, moderate increased risk, and high increased risk. The intensity of increased risk is dependent on the degree of relation. First-degree relatives are defined as parent, sibling, or child, and second-degree relatives are defined as aunt, uncle, or grandparent. Familial risk is also dependent on the age of diagnosis, specifically before age 60 or after age 60. Lower familial risk intensity is associated with an increased degree of relative and an increased age of diagnosis. Higher familial risk intensity is associated with a decreased degree relative and a decreased age of diagnosis. For example, a 60-year-old male with a mother diagnosed with colorectal cancer at age 45 has a higher familial risk intensity than a 60-year-old male with an uncle diagnosed with colorectal cancer at age 75. Let's take a closer look at familial risk. Organized screening programs target average risk individuals aged 50 to 74. We are looking for people who do not think they have colorectal cancer and have no reason to think they may be diagnosed. The average risk population includes those 50 to 74 years of age who are not experiencing symptoms of colorectal cancer, have no personal or familial history of colorectal cancer adenomatous polyps, and no diseases of the colon that require monitoring by colonoscopy. For example, Crohn's disease or ulcerative colitis. The recommendation for average risk individuals, age 50 to 74, is to do an FOBT every 2 years. Individuals at moderate increased risk have one first-degree relative diagnosed with colorectal cancer or high-risk adenomas at age 60 or over, or 2 or more second-degree relatives diagnosed with colorectal cancer or high-risk adenomas at any age. HRA stands for high-risk adenoma, which includes advanced adenomas and or individuals with 3 or more adenomas. Adenomas are considered advanced when there is presence of high-grade dysplasia, villus components, and they are greater than or equal to 1 centimeter in size. The recommendation for moderate increased risk individuals is they are typically not recommended to participate in organized home screening colorectal cancer testing. Colonoscopy is recommended every 10 years starting at age 40 or 10 years earlier than the youngest relative's age of diagnosis. Screening with an FOBT starting at age 40 may be an alternative at this level of moderate increased risk. Individuals at high increased risk have one first-degree relative diagnosed with colorectal cancer or 1 or more high-risk adenomas under the age of 60, or 2 or more first-degree relatives diagnosed with colorectal cancer or 1 or more high-risk adenomas at any age. The recommendation for those in this high increased risk category is that they are not recommended to participate in organized home screening colorectal cancer testing. Colonoscopy every 5 years starting at age 40 or 10 years earlier than the youngest relative's age of diagnosis. Currently, Manitobans at moderate increased risk or high increased risk are not monitored by the ColonCheck program and must seek care from their healthcare provider. In 2016, the Canadian Task Force on Preventative Health released their colorectal cancer screening recommendations. Most adults 50 to 74 years of age should be screened every 2 years with an FOBT or every 10 years with a flexible sigmoidoscopy. Those ages 60 to 74 came with a strong recommendation with moderate quality evidence, and those 50 to 59 came with a weak recommendation, moderate quality evidence. The task force believes the FOBT or FIT and the flexible sigmoidoscopy are both reasonable screening tests for patients aged 50 to 74 based on randomized controlled trial evidence. As well, although the relative benefits are similar for both age categories, the absolute benefits are smaller in those aged 50 to 59 due to the lower incidence. Hence the weak recommendation to screen those aged 50 to 59 as compared to the strong recommendation for those aged 60 to 74. The task force does not recommend using colonoscopy as a screening tool, nor does the task force recommend screening those 75 years of age and older. While colonoscopy may offer benefits similar to flexible sigmoidoscopy, direct randomized controlled trial evidence of its efficacy in comparison to other tests like the FIT is currently lacking. Other issues include wait times, lack of resources, and a greater potential for harm from the procedure. Secondly, the recommendation to stop screening at age 75 is based on reduced life expectancy in older age groups, as well as the included ages in the randomized controlled trials identified in the systematic review. Although no RCTs have shown improvement in colorectal cancer mortality or morbidity for adults over the age of 74, existing trials are underpowered to detect a clinically important difference in this population. However, given that incidence rises with age and that this recommendation is based on low-quality evidence, adults over 74 years of age who do not have illnesses which affect their quality of life and or their lifespan may be less concerned with a lack of trials showing benefit or the potential harms. They should discuss screening with their primary care provider to determine their most appropriate screening option based on their personal values and beliefs. Based on a Manitoba survey conducted by Prairie Research Associates, the top 2 reasons for not completing an FOBT include 19% of respondents did not think it was necessary, and 75% of those who responded said that their doctor did not recommend the test to them. Your recommendation counts. To lower a person's colon cancer risk, ColonCheck recommends living a healthy lifestyle and getting checked every 2 years with an FOBT. Living a healthy lifestyle means eating food high in fiber, getting regular physical activity, limiting alcohol intake, being smoke-free, and limiting intake of red meat and processed meat. ColonCheck also recommends men and women aged 50 to 74 do an FOBT kit every 2 years. ColonCheck uses the Occult 2 Sensa FOBT. F stands for fecal, or stool. O stands for occult, or hidden. B is for blood, and T is for test. When a person has a polyp or polyps in their colon, it can cause intermittent bleeding. A home screening test, or FOBT, can see what we cannot see, blood in the stool. If someone tests positive, it does not necessarily mean that they have polyps or cancer. Rather, they need a more invasive test to examine the cause of their bleeding. The key here is that if someone has a positive FOBT, we can investigate further with a colonoscopy and remove any polyps to prevent the cancer from starting. If someone can see blood in their stool, the FOBT is not the right test for them. ColonCheck encourages primary care providers to be aware of the potential benefits and potential harms of colorectal cancer screening to facilitate an informed decision-making process. Potential benefits of the FOBT include randomized controlled trials have shown regular screening with the FOBT can reduce deaths from colorectal cancer by up to 25%. Also, precancerous polyps and other abnormal tissue can be removed during a colonoscopy, preventing the progression to colorectal cancer. And thirdly, detecting cancer at an early stage may result in simpler treatment, more treatment options, less need for chemotherapy, and decreased mortality from the disease. Potential harms include false positives and false negatives, as well as anxiety from the screening test and any follow-up testing required. Colonoscopy, the recommended follow-up test for individuals with a positive FOBT, can cause bleeding and perforation of the colon. The only dietary requirement for patients is to limit vitamin C intake to less than 250 milligrams per day for 3 days before and during the time the test is taken. Stool samples should be taken from 3 different bowel movements, preferably over 3 separate days, and mailed within 7 days. The lab must analyze the test within 14 days of the first stool sample to ensure accuracy of the result. In terms of test analysis, the test is looking for trace amounts of heme in the blood in the stool. It is a qualitative test where during analysis a chemical is placed on the sample, and if it turns blue, the test is positive. The number of positive or negative windows is not reported, as it does not indicate the stage of the disease. We merely test positive or negative for blood. If all 6 samples are negative, the result is negative. If any one of the 6 samples is positive, the result is positive. Blood in the stool is intermittent, so we do not recommend doing a second home screening test if the first result is positive. All positives should be investigated. An unsatisfactory or indeterminate result occurs when the lab is unable to provide a result. Reasons for an unsatisfactory result include any one of the 6 samples is missing, and the result of the remaining windows are negative. Any sample has been collected outside of the 14-day window. A sample is placed on the wrong side of the test card. A sample is too thick or too thin to read. A test card has expired. Or the lab has analyzed the test too soon. The lab should not analyze the test within less than 3 days of the last collection. That being said, if any window is completed and the result is positive, the test is positive. When an FOBT is completed, there are 3 possible pathways. If the result is normal or negative, which it is in approximately 94% of cases, a letter is mailed to the client and to the primary care provider to notify them of the negative result. And a recall letter will follow in 2 years' time, recalling the client to participate in colorectal cancer screening through ColonCheck. If a result comes back as indeterminate, which it does approximately 1.5% of the time, the client is contacted and a repeat test is sent up to 2 additional times. After the 3rd attempt, if a satisfactory result is not obtained, the client is referred to their doctor, as an FOBT test may not be the best test for the client. And thirdly, if a result comes back as positive, which it does approximately 4.5% of the time, our follow-up coordinator contacts the client by phone to advise them of the positive result. This is followed up by a letter to the client and to their healthcare provider. ColonCheck will initiate colonoscopy referral for all clients whose healthcare provider has previously given us permission to refer. If permission has not been granted, We expect that the client's healthcare provider will manage the referral for follow-up. For Winnipeg ColonCheck referred clients, a pre-colonoscopy appointment occurs with our nurse practitioner to review the client's health history, the colonoscopy procedure, and the bowel prep. Please note that ColonCheck does not facilitate colonoscopy for tests not done through our program. This pathway can be found on our website at getcheckedmanitoba.ca. So how is Manitoba doing? Approximately 50% of the eligible population in Manitobans are up to date with their colorectal cancer screening. To read more about specific screening rates, please visit our website at getcheckedmanitoba.ca. We have a variety of resources available to support you in your colon cancer screening work, including information brochures, what you need to know about preventing colon cancer and colonoscopy, and instructions on how to do an FOBT in a variety of languages, including English, French, Chinese, Filipino, German, Punjabi, Vietnamese. We also have instructional videos on how to do an FOBT kit on our website, so visit us at getcheckedmanitoba.ca to view our resources or place an online order. We also have a variety of other resources, FAQs, pathways, posters to help educate your patients, as well as a document that explains all of the food sources of vitamin C. We also have a healthcare provider website specifically made for healthcare providers about cancer screening for breast, cervix, and colon. On this website, we have information about screening guidelines, resources for supporting your patients, program operations, education and continuing medical education event opportunities, as well as reports and other tools to help support your work with patients. There are 3 ways to obtain an FOBT kit from ColonCheck. Our hope is always that a client will respond to our initial invite that comes in the mail. However, if that does not happen, Manitobans can also request one at getcheckedmanitoba.ca or by phone, calling us at 1-855-95-CHECK. For clients unlikely to request their own kit, healthcare providers can request a kit with the permission of their client using the FOBT request form. The colorectal cancer screening fecal occult blood test request form is in EMR ready to be populated and faxed to ColonCheck. Before sending in the form on your client's behalf, get consent from your client, ensure the contact information is verified, populate with the client information, fax to ColonCheck. Once we have the form, we will check to see if the client is eligible in our database. If the client is ineligible, ColonCheck will fax the referring provider with the reason for ineligibility. If the client is eligible, ColonCheck will mail the client a kit and they will follow the usual ColonCheck pathway. For more information, visit us at getcheckedmanitoba.ca or call us at 1-855-95-CHECK.